Dear students, in this session, let us discuss the principles of drug therapy. First of all, let us see absorption of drugs. Absorption is the transfer of a drug from the site of administration to the systemic circulation. The rate and extent of absorption depend on the environment where the drug is absorbed, chemical characteristics of the drug, and the route of administration which influences bioavailability. Routes of administration other than intravenous may result in partial absorption and lower bioavailability. Mechanisms of absorption of drugs from the gastrointestinal tract. Depending on their chemical properties, drugs may be absorbed from the GI tract by passive diffusion, facilitated diffusion, active transport, or endocytosis. First, let us see passive diffusion. The driving force for passive absorption of a drug is the concentration gradient across a membrane separating two body compartments. In other words, the drug moves from a region of high concentration to one of lower concentration. Passive diffusion does not involve a carrier, is not saturable, and shows a low structural specificity. The vast majority of drugs are absorbed by this mechanism. Water-soluble drugs penetrate the cell membrane through aqueous channels or pores, whereas lipid-soluble drugs readily move across most biological membranes due to their solubility in the membrane lipid bilayers. Now let us discuss facilitated diffusion. Other agents can enter the cell through specialized transmembrane carrier proteins that facilitate the passage of large molecules. These carrier proteins undergo conformational changes, allowing the passage of drugs or endogenous molecules into the interior of cells and moving them from an area of high concentration to an area of low concentration. This process is known as facilitated diffusion. It does not require energy, can be saturated, and may be inhibited by compounds that compete for the carrier. Active transport. This mode of drug entry also involves specific carrier proteins that span the membrane. A few drugs that closely resemble the structure of naturally occurring metabolites are actively transported across cell membranes using specific carrier proteins. Energy-dependent active transport is driven by the hydrolysis of adenosine triphosphate or ATP. It is capable of moving drugs against a concentration gradient, that is from a region of low drug concentration to one of higher drug concentration. The process is saturable. Active transport systems are selective and may be competitively inhibited by other co-transported substances. Let us see endocytosis and exocytosis. This type of absorption is used to transport drugs of exceptionally large size across the cell membrane. Endocytosis involves the engulfment of a drug by the cell membrane and transport into the cell by pinching of the drug-filled vesicle. Exocytosis is the reverse of endocytosis. Many cells use exocytosis to secrete substances out of the cell through a similar process of vesicle formation. Vitamin B12 is transported by endocytosis, whereas certain neurotransmitters, for example norepinephrine, are stored in intracellular vesicles in the nerve terminal and released by exocytosis. Factors influencing absorption. Medication taken orally may be absorbed from any part of the gut. Highly lipid-soluble drugs may be absorbed from the buccal cavity, from where it directly enters the systemic circulation. Acidic drugs are absorbed from the stomach, while basic drugs get ionized and are not absorbed from the stomach. Basic drugs given intravenously may diffuse from blood into the stomach because of the pH and may ionize quickly. This is known as ion trapping. Intestines have a large surface area and most drugs are absorbed from the proximal part of the jejunum. Basic drugs are absorbed from the intestine because of the favorable pH. Various factors like intestinal motility and pH influence the absorption from the gut. It has now been found that drugs may be transported out from the cells of the intestinal wall back into the gut lumen. This is done with a reverse transporter or efflux transporter P-glycoprotein. Absorption from the large intestine is negligible. Several factors influence the rate and extent of absorption of a drug given orally. Now let us move on to the disintegration and dissolution time. The drug taken orally should break up into individual particles or disintegrate to be absorbed. It is then has to dissolve in the gastrointestinal fluids. In case of drugs given subcutaneously or intramuscularly, the drug molecules have to dissolve in the tissue fluids. Liquids are absorbed faster than solids. Delay in disintegration and dissolution, as with poorly water soluble drugs like aspirin, result in delayed absorption. Blood flow to the absorption site. The intestines receive much more blood flow than the stomach. So, absorption from the intestine is favored over the stomach. Total surface area available for absorption. With the surface rich in brush borders containing microvilli, the intestine has a surface area about 1000-fold that of the stomach, making absorption of the drug across the intestine more efficient. Formulation. Pharmaceutical preparations are formulated to produce desired absorption. Inert substances used with drugs as diluents like starch and lactose may sometimes interfere with absorption. Now let us see the effect of pH on drug absorption. Most drugs are either weak acids or weak bases. Acidic drugs release a proton or H+, causing a charged anion A-. Weak bases can also release an H+. However, the protonated form of basic drugs is usually charged, and loss of a proton produces the uncharged base. A drug passes through membranes more readily if it is uncharged, as in figure 3. Thus, for a weak acid, the uncharged protonated HA can permeate through membranes and A- cannot. For a weak base, the uncharged form B penetrates through the cell membrane, but the protonated form BH+ does not. Therefore, the effective concentration of the permeable form of each drug at its absorption site is determined by the relative concentrations of the charged and uncharged forms. The ratio between the two forms is in turn determined by the pH at the site of absorption and by the strength of the weak acid or base, which is represented by the ionization constant pKa. Here the pKa is a measure of the strength of the interaction of a compound with a proton. The lower the pKa of a drug, the more acidic it is. Conversely, the higher the pKa, the more basic is the drug. Distribution equilibrium is achieved when the permeable form of a drug achieves an equal concentration in all body water spaces. Particle size. Small particle is important for better absorption of drugs. Drugs like corticosteroids, glycofulfin, digoxin, aspirin and tolbutamide are better absorbed when given as small particles. On the other hand, when a drug has to act on the gut and its absorption is not desired, then particle size should be kept large. For example, antihelmintics like bifenium hydroxynaphthate. Now let us see the lipid solubility. Lipid soluble drugs are absorbed faster and better by dissolving in the phospholipids of the cell membrane. Gastrointestinal motility. Gastric emptying time. If gastric emptying is faster, the passage of the drug to the intestines is quicker and hence absorption is faster. Intestinal motility. When highly increased, as in diarrhea, drug absorption is reduced. In this figure, you can see the diffusion of the non-ionized form of a weak acid through a lipid membrane. And in B, you can see the diffusion of the non-ionized form of a weak base through a lipid membrane. In figure 4, you can see the distribution of a drug between its ionized and non-ionized forms, which depends on the ambient pH and pKa of the drug. For illustrative purposes, the drug has been assigned a pKa of 6.5. Presence of food delays gastric emptying, dilutes the drug and delays absorption. Drugs may form complexes with food constituents and such complexes are poorly absorbed. For example, tetracyclines chelate calcium present in the food, hence their bioavailability is decreased. Moreover, certain drugs like ampicillin, roxithromycin and rifampicin are well absorbed only on empty stomach. Diseases of the gut like malabsorption and achlorhydria result in reduced absorption of drugs. Metabolism. Some drugs may be degraded in the gastrointestinal tract or first pass metabolism occurs. Example, nitroglycerin and insulin. Such drugs should be given in higher doses or by alternative routes. Expression of P-glycoprotein. P-glycoprotein is a transmembrane transporter protein responsible for transporting various molecules, including drugs, across cell membranes. It is expressed in tissues throughout the body, including the liver, kidneys, placenta, intestines and brain capillaries, and is involved in transportation of drugs from tissues to blood. That is, it pumps drugs out of the cells. Thus, in areas of high expression, P-glycoprotein reduces drug absorption. In addition to transporting many drugs out of cells, it is also associated with multi-drug resistance. Now, let us see the absorption from parenteral route. On intravenous administration, the drug directly reaches the circulation. On intramuscular injection, the drug molecules should dissolve in the tissue fluids and then be absorbed. Since muscles have a rich blood supply, absorption is fast. Drug molecules diffuse through the capillary membrane and reach the circulation. Lipid-soluble drugs are absorbed faster. Absorption from subcutaneous administration is slower, but rate of absorption is somewhat steady. Inhaled drugs are rapidly absorbed from the pulmonary epithelium, particularly the lipid-soluble ones. On topical application, highly lipid-soluble drugs are absorbed from the intact skin. Example, nitroglycerin. But absorption is relatively slow because of the multiple layers of closely packed cells in the epidermis. Most drugs are readily absorbed from the mucous membranes. Now, let us see what is bioavailability. Bioavailability is the rate and extent to which an administered drug reaches the systemic circulation. For example, if 100 mg of a drug is administered orally and 70 mg is absorbed unchanged, the bioavailability is 0.7 or 70%. Determining bioavailability is important for calculating drug dosages for non-intravenous routes of administration. Transdermal preparations are absorbed systemically and may have 80 to 100% bioavailability. Large bioavailability variations of a drug, particularly when it is unpredictable, can result in toxicity or therapeutic failure, as in case of halofantrine. Now, let us see the determination of bioavailability. Bioavailability is determined by comparing the plasma levels of a drug after a particular route of administration, for example, oral administration, with levels achieved by intravenous administration. After intravenous administration, 100% of the drug rapidly enters the circulation. When the drug is given orally, only part of the administered dose appears in the plasma. By plotting plasma concentrations of the drug versus time, the area under the curve or AUC can be measured. The total AUC reflects the extent of absorption of the drug. Bioavailability of a drug given orally is the ratio of the AUC following oral administration to the AUC following intravenous administration, assuming intravenous administration and oral doses are equivalent. Here you can see the determination of the bioavailability of a drug, where AUC represents the area under curve and IV represents the intravenous administration. Factors that influence bioavailability. In contrast to intravenous administration, which confers 100% bioavailability, orally administered drugs often undergo first pass metabolism. This biotransformation, in addition to the chemical and physical characteristics of the drug, determines the rate and extent to which the agent reaches the systemic circulation. First pass hepatic metabolism. When a drug is absorbed from the gastrointestinal tract, it enters the portal circulation before entering the systemic circulation. It is also called pre-systemic metabolism or first pass effect and is an important feature of oral route of administration. If the drug is rapidly metabolized in the liver or gut wall during this initial passage, the amount of unchanged drug entering the systemic circulation is decreased. The extent of first pass metabolism differs from drug to drug and among individuals from partial to total inactivation. When it is partial, it can be compensated by giving higher dose of the particular drug, example nitroglycerin, propranolol and salbutamol. But for drugs that undergo complete first pass metabolism, the route of administration has to be changed. Example, isoprenaline, hydrocortisone and insulin. Bioavailability of many drugs is increased in patients with liver disease due to reduction in hepatic metabolism. Now let us see the solubility of the drug. Very hydrophilic drugs are poorly absorbed because of their inability to cross lipid-rich cell membranes. Paradoxically, drugs that are extremely lipophilic are also poorly absorbed because they are totally insoluble in aqueous body fluids and are therefore cannot gain access to the surface of cells. For a drug to be readily absorbed, it must be largely lipophilic, yet have some solubility in aqueous solutions. This is one reason why many drugs are either weak acids or weak bases. Chemical instability. Some drugs such as penicillin G are unstable in the pH of the gastric contents. Others such as insulin are destroyed in the gastrointestinal tract by degradative enzymes. Nature of the drug formulation. Drug absorption may be altered by factors unrelated to the chemistry of the drug. For example, particle size, salt form, crystal polymorphism, enteric coatings and the presence of excipients such as binders and dispersing agents can influence the ease of dissolution and therefore alter the rate of absorption. Now let us see bioequivalence. Two drug formulations are bioequivalent if they show comparable bioavailability and similar times to achieve peak blood concentrations. Therapeutic equivalence. Two drug formulations are therapeutically equivalent when they are pharmaceutically equivalent. That is, they have the same dosage form, contain the same active ingredient and use the same route of administration with similar clinical and safety profiles. Clinical effectiveness often depends on both the maximum serum drug concentration and the time required after administration to reach peak concentration. Therefore, two drugs that are bioequivalent may not be therapeutically equivalent. Before we move to the next session, please try to answer the following questions. First, discuss absorption processes and factors affecting the absorption. Next, define bioavailability and factors that influence bioavailability. References: Basic Pharmacokinetics and Pharmacodynamics, an integrated textbook and computer simulations by Rosenbaum and Sarah E., published by John Wiley and Sons in 2012. The Pharmacological Basis of Therapeutics by Joel Griffith Hardman, Lee E. Limbird and Alfred G. Gilma. Davidson's Principles and Practice of Medicine, a textbook for students and doctors by Edwards CRW and Ian A. D. Bouchier in 1992. Hope this session was useful to you. See you next time. Until then, bye.